Please join me in welcoming Dr. Reintjes.
Oh, thank you, Randy.
How you doing today?
I'm doing great. Thanks for having me.
Absolutely. We're excited to learn a little bit about the latest with arthritis.
Well, perfect. This is what we're going to talk about today. We're going to focus mainly, we're going to talk about arthritis, but really going to focus on arthritis related to back and neck pain, because that is my specialty and that's what I do all day.
Very interesting. All right.
So let's get started. So again, my name's Stephen Reintjes. Thanks for having me. Today, I want to essentially define what arthritis is, and I want to go over some basic factors and epidemiologic factors surrounding arthritis. We'll look at a few slides detailing the anatomy of the lumbar spine in particular, and then we'll go over causes for back pain and arthritis. We'll go over a few real-world examples of patients that I've seen in clinic and even surgical patients, but we'll go over the main treatments for arthritis and the conservative or non-surgical treatments. And then lastly, we'll touch briefly on any surgery options there are for patients with arthritis. And as always, there's lots of good cartoons, or many good cartoons for patients with back pain. And this is a cartoon on the right of a mechanic, of a guy taking his car to a mechanic, and he says there are lots of creaking and popping, but the mechanic says it's your car's fine. It's actually your knees that are that goes down the creaking and popping. There are lots of causes of back pain, and they can range from behavioral, cognitive, psychosocial, but really today we're going to talk about degenerative causes of back pain, and arthritis really plays into the degenerative causes. With arthritis comes neurologic problems, and that's when patients feel back pain oftentimes have neurological problems as well, such as numbness and tingling or pain in their lower extremities. As you can see, the causes of back pain are widespread. It ranges from having a structural problem. At the top left and the middle left column there, it gets into the arthritis related causes of back pain, but as you can see, there's virtually dozens, even hundreds of causes of back pain. So it's a fairly common problem that we see all the time. This is a slide which explains the global burden of back problems on overall quality of life. And this is the Institute for Health Metrics and Evaluations. This is a great tool to use, and I encourage anybody who's interested to go to ihme.com and you can play around with the tool. But this really describes the burden of back pain. So you can see in the red box, I've highlighted a few orthopedic or arthritis-related conditions such as back pain, neck pain, osteoarthritis, and other musculoskeletal diseases. This graph shows the cause of years of life lived with a disability in the United States for all ages in both genders. This is for the year 2019. As you can see, back pain accounts for just over 11% of all cause of years of life lived with disability. And if you encompass back, neck pain, osteoarthritis, and other musculoskeletal diseases, that's 25% of all of years life lived with a disability. So it's a huge burden on our population, and something that most people will have to deal with at some point in their lifetime. When dealing with back problems or arthritis, there's several terms that we have to get familiar with. A lot of times there's a term that we use in the community, and then there's a term that we use in talking to colleagues, or especially in radiology reports. And so if anybody's had an MRI or an X-ray or anything, they will find these terms, and the terms are often interchangeable. So a lot of times we'll use the term arthritis on a report that may be referred to as spondylosis, or may be talking to another physician about patient spondylosis. Bone spurs are extremely common. Those are referred to as osteophytes. Slip discs are often referred to as a spondylolisthesis in an MRI and X-ray report. Bulging disc, herniated discs are often used interchangeably. The radiologists have more concrete definitions of both of those, but we use them interchangeably. Sciatica classically refers to a radiculopathy or pain going down the back of the leg. And a facet and joint are used interchangeably as well. We also talk about degenerative disc disease and stenosis. And so all these terms are things that you may hear. You have spondylosis, but really this means you have arthritis, and those terms will be used interchangeably. So what is arthritis? At its most fundamental level, arthritis is a disorder that affects the joints. So that leads us to, what is a joint? A joint is any connection between two bones. So we have joints all over our body. Sometimes we think of the large joints such as a knee, ankle, a hip, shoulder, elbow. Those are complex joints. Other joints are small joints we have throughout our lumbar spine, as we'll see in a minute. So, but it's any connection between two bones. Of arthritis, there's over 100 types of arthritis. This ranges from osteoarthritis to rheumatoid arthritis to spondylitis and anything in between. So, but there's over 100 types. But today we're mainly going to focus on osteoarthritis of the lumbar spine, which is a degenerative condition. So we're going to talk about anatomy a little bit. Throughout your spine, there's three main sections. There's the cervical, which is the top, the thoracic, which is the middle, and then the lumbar, which is the bottom. Each of those levels has a natural curvature in the lumbar, and the thoracic, and the cervical. Each of those has at least 4 to 6 joints at each level. So you can imagine there's lots of opportunity to have arthritis throughout the spine, especially in the lumbar spine, because it tends to be mobile, and that gives us our flexibility. This is just a schematic showing on the left here is a vertebral body, and shows one segment of the lumbar spine. You can see the vertebral bodies up top, and then the disc in between. And those arrows pointing up and down are showing the facet joints and showing the range of motion and flexibility of the lumbar spine. On the right side, it shows, this is a view of the lumbar spine from the back. So you can see the vertebral body in the front. In the back, there's the lamina, and each segment in the lumbar spine has 4 connections, or 4 facets, or 4 joints. So there's an opportunity for arthritis at 4 locations in each spot in the lumbar spine. So you can imagine there's lots of opportunity for arthritis. This is another schematic of something we just looked at on the left side. And on the right side is an MRI. And this kind of shows us what is going on when we look at an MRI and we're talking to patients. In the middle, you can see the canal with all the nerve roots. On the right side, it shows the lamina, and then the lamina turns into the facet, or the joint. And there's 2 parts, the superior and inferior, and you can see the facet right there, and it's highlighted in yellow. You can also see the nerves as they're leaving the spine. And this would be considered an axial view. And I know we're talking about joints and talking about facets, but we can't talk about lumbar anatomy without talking a little bit about the muscles. Not only do we have lots of joints and connective tissue, but the muscles are also really important in the structural integrity of our back and keeping us upright. But also, like anything, muscles can get sore and can cause pain as well. So like I mentioned, each vertebra, especially in the lower lumbar spine, has 4 facet joint surfaces. So that's really, if you think about it, that's 4 areas per level. There's 5 levels in the lumbar spine, and there's other connections as well. So there's over 40 joints alone in the lumbar spine. Now, if we zoom out and look at the spine as a whole, there's over 300 joints in the entire spine. So if you think about it, that's 300 opportunities for us to develop arthritis and cause pain. So that's part of the reason why joint problems or back problems are so prominent. But the joints are crucial because they allow us flexibility. They allow us to bend and move, and to do various yoga poses or perform in athletics. You know, there's this concept in looking at spine deformity and spine surgery is the cone of balance. And what really allows us that cone of balance in this range where we can feel comfortable is our joints, and that's how flexible we are. So these are just a few real world examples of patients that I've seen. This is something we see every day. This is a patient who's in his mid-60s. You can see this is the left two images are a CT scan. The left one is an axial view and the middle one is a sagittal view. You can see that, I don't think this will show up, but the facets are enlarged. They have arthritis in them. And what happens is when the facets or the joints enlarge due to arthritis, they grow outward, but they also grow inward. And when they grow inward, they can put pressure on the nerve and cause back pain and cause leg pain. They can also create bone spurs. You can see the middle image, kind of right in the middle, there's a large bone spur that's pushing in on where the nerve lives. And the far right image is an MRI of the same level as the CT scan. And the MRI shows that the nerves in the middle look okay, but kind of out in the corners, that facet or that bone has gotten hypertrophied or gotten a lot bigger due to arthritis and is putting pressure on the nerve. This is another example. This is an MRI on the left and the right. The left MRI is a kind of a sideways cut through the back, and it shows, you can see the bone, the vertebrae, and the disc, and the bone below. There's a little bit of a slip, so the bones aren't quite lined up, and that causes tugging on the nerves. And on the right image, you can see why. This is an axial cut of the MRI of the lumbar spine, but you can see the facets and the joints, they have arthritis in them. They've hypertrophied or gotten bigger, and they've grown outward, but they've also grown inward. And now they're putting pressure on a nerve, causing back pain and leg pain. And not only have the joints or the bones gotten bigger, but also the ligaments and the things that keep the bones together have gotten thicker, and that can put pressure on the nerve as well. And this is another example. This is a CT scan of a patient with severe arthritis. You can see the bones look very irregular. There's a lot of bone spurs. The discs have worn down, and there's severe degenerative disc disease, which can also, again, put pressure on the nerves. And this is a kind of a severe example of a patient with severe degenerative problem and severe arthritis of their low back. And this is the last example. This, again, on the left, these are both MRI images. On the left, it's kind of a cross section through the back. You can see the vertebral bodies, and there's the disc in the middle, but the area where the nerves it just looks tight, in the area where the nerves are pinching. The cross section through this area is on the right-hand image, and it shows that the joint has gotten bigger. It's hypertrophied. Again, it's grown inward, and the ligament has gotten thicker, and now it's putting pressure on the nerve, and there's just not enough room for the nerves to grow and the nerves to live, to be happy. And this is the last example. This is sort of an extreme example of a patient with a relatively normal looking spine on the top, but as we get lower in the spine, there's this patient is a woman in her 50s with rheumatoid arthritis, and it's affected the spine, and it's causing, you can see the severe damage, irregular borders, and it causes kind of pulling and pinching of the nerves as well. And this is kind of an extreme example, but it's an example of what can happen with severe osteoarthritis or rheumatoid arthritis. So when we're dealing with arthritis pain, there are several treatment options, and no treatment option is perfect. But oftentimes we take a multi-stage approach or multidisciplinary approach to treating these problems. Usually it's not just try one thing. If it doesn't work, well, that's what we're stuck with. We don't have to, no, we try a lot of things. And oftentimes if you see your primary care doctor or a physical medicine or rehab doctor or a pain doctor or even a surgeon about this, we may often say, well, you've got this problem and we want to attack it. We want to try several things at once to see if we can get this figured out. That being said, most patients at some point in their life will have back pain or neck pain. And a lot of patients are family members of yours, may say, well, I've had this problem, but I'm just dealing with it. I'm doing stretches at home. I'm doing a little bit of exercising. I'm taking some over-the-counter medicines. And a lot of times for most people, that's good enough. And that's, they find relief with those treatments. And for those that don't and seek other care, that's where we try other things. And then no treatment modality is perfect. So, what works for some person may not work for another person. So really it's just kind of a little bit of trial and error, trying to figure out what works for you. This is another funny cartoon. And so with arthritis, there's no perfect option. Often it's very difficult to kind of make modified behaviors, and sometimes it's easier. A lot of times patients come in and say, listen, I'm really uncomfortable. I say, I wish there was a silver bullet, but we've got to change a few things here. We got to work together to make sure, see if we can get better. But obviously pills and surgery sometimes are the easiest way out. For non-operative measures, the mainstay of treatment are rest and over-the-counter medicines. And like I said, most people will try that before they come to see their physician. And a lot of times those work. Narcotics or opioids in the short term may be beneficial, but for the most part, they're not really good long-term treatment options for patients with arthritis. And the patients that are not moving as much, really, we try to focus on physical medicine, rehab, physical therapy. And oftentimes patients will come in and we'll recommend that, or they've tried it or have had a family member that tried it. And it's really physical therapy is kind of the mainstay. And then I'll talk later about Move Plus, which is our program here at North Kansas City Hospital, which has really good results for patients with longstanding low back pain. Another mainstay of treatment is pain management. So we work closely with our pain management colleagues here. The workhorse of pain management would be epidural steroid injections. So the pain doctor would use X-ray to localize where the pain's coming from and inject a small dose of steroid right near that joint that's causing pain. That can help quite a bit. They also have several tools in their toolbox that can help, including nerve blocks, ablations, even spinal cord stimulation. That can be very helpful. And then kind of the secondary treatment options can be extremely helpful, but those are acupuncture, yoga, dry needling, chiropractic care can all be helpful and to help arthritis related back pain. I would be remiss to say if we didn't talk about ergonomics. Obviously, ergonomics are extremely important. Patients with back pain or arthritis-related pain will often note that sometimes certain positions will help more than others. So if they're lying down, that might help. And if they're standing for long periods, that may make their symptoms worsen. Ergonomics is an important part of that. And for those of us that like to check our cell phone often or frequently getting text message, this picture shows the relative weight of the head as we're bending our neck forward. So if we're bending down to check our phone, if it's tilted about 60 degrees, that adds about 60 pounds of weight to your head. So it's like you're walking around with a 60-pound weight on your head. It's a little bit less the shallower the angle, but it just goes to show you that ergonomics are really important, and upright posture are really important in order to maintain a healthy balance and try to limit that arthritis-related symptoms. So again, posture is really important. For those who are sitting a lot or standing a lot at work, ergonomics, core stabilization is a mainstay of rehab and physical therapy. And there's several ways to achieve that. Again, with manual traction and physical therapy, there's soft tissue mobilization, joint manipulation, myofascial releases. All are tools that physical therapists, sometimes even chiropractors, might use in order to relieve joint-related pain or arthritis-related symptoms. And a lot of that biofeedback is really helpful and can provide significant relief in adjunct with other treatments. They might also offer ultrasound or a TENS unit or electrical stimulation, which that biofeedback and traction, which can also help quite a bit. The traction helps because because your spine is flexible, the traction actually pulls at the joints and the ligaments a little bit, but that kind of stretches things out. It can provide relief. And then lastly, Move Plus. Move Plus is a proprietary program here at the hospital, and a lot of people consider it therapy, but it's actually a lot more than therapy. And the champion of this program is our physical therapy director, Sue Condon, and she and I helped to kind of design this. And Sue had a lot of experience before she came here to design this program at the hospital. So you can only find it here. It's designed to reduce pain and improve function, improve mobility. The nice thing about this is that every program is individualized, and so you have an individual part to this and also group-based therapy. There's a lot of education, and it's a really good program. A lot of times patients come in, they say, well, I've tried therapy. I'm not necessarily sure I want to try it again. I say, this is different. This is physical therapy plus. It goes beyond just regular physical therapy and does a lot of core strengthening and strength exercises. So it's a very, very good program. And then, like I talked about, the multi-specialty rehab, biopsychosocial, that's kind of incorporates everything, and that's kind of an option as well. It's not for everybody, but it does have a good effect on pain and disability. Obviously, when you come into your physician or go to the therapist, everybody's going to ask you about your pain. Obviously, not everything is a 10 out of 10, even if it feels like that. That's why it makes it so hard, because everything feels like it's the worst pain ever. And so it's really important to try to, identify what your pain is when you start any sort of therapy or treatment or rehab, and write it down. Is this a 10 out of 10? Is it an 8 out of 10? And then go through the treatment of medicines for a month, or physical therapy or injections, and then reassess yourself after 4 weeks and after 8 weeks to see where your pain is. So you want to see, okay, I was at 8 4 weeks ago or 6 weeks ago. Am I a 5? Am I a 3? Is this, can I live with this? Oftentimes if we can get a 60% reduction in pain, people are very happy with that. So, but it's important to write it down, because otherwise we tend to forget. So, and then the last option for patients with severe arthritis or pressure on the nerves would be surgery. Surgery, typically we would try to recommend a conservative treatment, because a lot of patients will feel better with a non-surgical approach first, and they won't even need to proceed. And for some patients, they've had surgery elsewhere before and they have other problems, and then they come back and need to have something else looked at. But remember, surgery is not the answer for all problems. But we've made technological advancements with surgery, and so surgery can be helpful. But like anything, if you've come to this point where you've tried conservative treatment and tried therapy or injections and it's still not getting better, your provider may recommend some imaging. And so we may get an MRI or CT monogram. Other imaging modalities are x-rays or a bone density scan. So these are going to help us identify the problem, like the examples that we used previously. But if we're going to get ready for surgery, we want to make sure patients are doing well. We want to optimize their nutrition status, and not the quintuple Big Mac that we see on the right side. We make sure that they're getting the right amount and the appropriate amount of calories every day. We want to check their smoking status, because make sure that they're either not smoking or trying to decrease their nicotine use. And also counseling. Counseling is a very important part of the surgical preparation process. The mainstays of surgery are laminectomy, a discectomy, or you may even hear a lumbar fusion. And there's a clear indication for each approach. So these are the mainstays. Laminectomy is the workhorse of any surgery. Laminectomy is a procedure where we remove that part of the bone to take the pressure off the nerve. The laminectomy is an old procedure, and I think it was the first described in the 7th century by a Greek philosopher and physician, so it was arguably the oldest and most common procedure, lumbar spine surgery performed today. So it's an old surgery, and it's still been around all these years because the reason is because it works. So this is going back to the first case that we reviewed. So we have the CT scan on the left and in the middle, and in the red circle, I highlighted the facet and the joint arthritis, as well as the bone spur. At the bottom of that red circle is the lamina. And so in surgery, what we will do is actually remove that part of the bone that's gotten bigger and hypertrophied, and putting pressure on the nerve. And by doing that, removing that arthritis or that bone spur, we can take the pressure off the nerve, and it relieves the patient's back pain as well as their leg pain. Over the last 20 years, surgery has, we've refined our surgical techniques. So the big focus has been minimally invasive spine surgery. The reason is smaller incisions, we've learned minimize soft tissue damage. It reduces the blood loss, reduces postoperative pain, means a shorter hospital stay, quicker recovery. So you come in, if you have surgery, use minimally invasive techniques to get you back to your current state quicker than before and decrease the recovery time. We want spine surgery, if you need to have it, to be kind of something you come in, have your surgery, and you go home and you return to your community better than when you came in. So obviously with minimally invasive surgery, we're focusing on the technique. With minimally invasive surgery, there's different access strategies to the spine. And sometimes we may just go through the back, but also coming through the front of the spine or coming to the side are also different access techniques. Navigation is a big part. So technology plays a big part in computer navigation to help make sure everything goes as planned. And then there's been advancements in the instrumentation and the implants. As you can see, this is just kind of goes over again what we talked about. Minimally invasive surgery, the goal is smaller incisions for less soft tissue damage, less blood loss, less scarring, postoperative pain, quick recovery, and returning to your things you like to do. So through the years, you can see on the left is kind of a traditional open surgery. And as we've evolved over the last 10 to 15 years, our incisions have become more refined and gotten smaller and smaller to the point where we can now do surgeries through really small incisions or ports, even in the low back. So I just have a couple of real world examples, and then we'll wrap it up, and I'll be happy to take any questions. So this is a patient in their mid-60s who had back pain and also pain going down both legs. And they had a little bit of a slip at L4-5 where you see that line. So the bones were sliding on each other. So because of the pressure on the nerves, we recommended a laminectomy, but because of that slipping, that kind of focal instability, we recommended stabilization. You can see the preoperative and postoperative MRI showing that the nerves that were compressed at that one point are completely decompressed, and then all that arthritis is gone at that level. So this would be what the x-ray looks like. You can see that the level that was treated has a little bit of an instability, a little bit of a slip. This patient had severe stenosis. So we recommended a laminectomy to take the pressure off the nerves and a fusion to stabilize those two segments. So the preoperative x-rays on the right and the postoperative x-rays on the left to help take the pressure off the nerves. You can see that the bones are now lined up, and you can't see the laminectomy because it doesn't show up on the x-ray, but you can see the bones are lined up and the pressure has been taken off the nerves. And this is a procedure through two small 4-centimeter incisions, and the patient can go home the next day even. This again is another slip. You can see on the left is an MRI at L5 and S1. That bone is slipped forward, and you can see the pressure on the nerves. In the middle picture, we have a cut through the middle of that section. You can see that the facets and the joints are a lot larger and hypertrophied, and there's not enough room for the nerves. So this is an approach. Actually, we talked about different corridors. We actually use the assistance of a vascular surgeon to make a small incision near the belly button to put a small spacer in the front and help pull the bone back. So you can see the postoperative x-ray on the right. The bone is pulled all the way back, and the spine is lined up, and the stenosis is treated. So once you have surgery, and if patients are still hurting, then we need to go back to the drawing board, and when all options are exhausted, and we need to do a thorough workup. And there's other imaging modalities that are not as common, but still some things we can use to help identify any remaining problems. So it's most chronic back pain is best treated non-operatively with conservative measures like I talked about. And when patients start to have arthritis related to back pain, but also it's causing leg symptoms, that's when it can be really helpful. And that's all I have.
Doctor, that's a tremendous amount of great information right there. Now, excuse me, getting a little choked up. So much to handle. I got choked up.
Yeah.
Now we've got several questions from our viewers that I want to get into with you. Take a minute to get yourself a drink there. First off, one of the people that are watching today asks, I know that arthritis affects my joints, but what about the rest of my body? Can it impact my brain, eyes, heart, kidneys, or lungs?
It can. And so, like I mentioned in the talk, there are over 100 types of arthritis, and the arthritis can affect any part of your body, not only the joints, but it can also attack your organs. You know, when in my practice in day-to-day, we're dealing mainly with osteoarthritis, but sometimes there's other forms of arthritis when they can affect other parts of the body. That's when we engage our rheumatologist colleagues here at the hospital, and we work together closely to kind of figure out, okay, what's the best treatment for this patient? Because that's not always about the back and the neck. Sometimes the other problems are affected as well. So it's important to be in contact with a rheumatologist, which is great that we have here at the hospital.
Absolutely. That's good to know. Another question from a viewer, can exercise help? And if so, how much and what type of exercises are appropriate for arthritis sufferers?
Exercise is very important, and we essentially recommend it to a lot of my patients. You know, physical therapy is therapy, but really just getting out, doing stretches, lifting light weights is extremely important and help maintaining the range of motion and mobility. And you think about it, your joints are two ones that are rubbing together, and there's a fluid in the middle. It's kind of like fluid or oil in your car. You need to keep those joints limber and keep moving, otherwise it can get stiff, and that's when the pain sets in. So it's really exercise is critically important in arthritis related back and neck pain. And then diet and exercise are obviously, diet is obviously important as well.
Another one, this ties in perfectly. Will stretching help me feel better?
Yeah, stretching is a form of exercise, in my opinion. You've seen the prevalence of new places like the Stretch Zone or the Stretch Lab, which are opening up next to the Starbucks in the strip mall. And that's the reason for that, is because they work and they're critically important to keeping those joints limber and keeping them moving.
Interesting. Another question, and this I think is on a lot of people's minds. If my symptoms get worse, what can I do to manage them on my own?
Well, the first thing is to move, whether it's just getting out walking or getting out stretching. When patients come into the office, a lot of times they just want to know what they can do at home. And so we have a sheet in our office that we hand to people. These are the stretches that we recommend for your back or for your neck, these exercises. The other thing is, the first mainstay is treatment with medicines, and that's the over-the-counter medicines, the anti-inflammatories, the Tylenol, and those kind of things.
Good to know. And let's see, the last question we have, I think at this point, is from somebody, and this is a really interesting one, I think. If I'm an arthritis sufferer, are my children likely to be affected by it as well? And if so, at what age will we start to see it?
So for osteoarthritis in particular, it's not necessarily true. You know, I think it's different for everybody. We do see sometimes back problems tend to run in families. And so sometimes if parents have it or there's a long family history, sometimes that does run in the family, but not necessarily. It doesn't mean your children are destined to have arthritis. So I think it's a little bit different for everybody.
Thank you very much. So much great information today. You know, we hope that today's presentation was informative and helpful for you. Remember to join us Thursday, August 17th for our next Lunch and Learn, Prostate Pressure Relief with Dr. Gerald Park, a urologist with Kansas City Urology Care. Again, thanks for joining us here this afternoon. Have a good rest of your day.